We have Dr. Silverstein, Dr. Keller, and Dr. Rosenberg for the Better Hearing Month Q&A panel. Our first question is, what is the number one cause of hearing loss at any age?
I think you have to divide the ages up because it's young people, children, and adults. In adults, the most common cause would be hearing loss of aging. That's usually hereditary. Most of us lose our high frequencies as we get older, and it's very common in the population. And in children, it's entirely different. They have the most common problem is fluid in their ears, or after a cold, their ears get blocked up, and that's a temporary type of hearing loss, where the high frequency loss of aging is not reversible.
I think we have to include excessive loud noise exposure. If it's not an age-related loss, I think the number one cause would be due to some excessive loud noise exposure.
Okay, the next question. How often should a person with no known hearing loss get a hearing test?
We usually order hearing tests when the patients are 60 years of age, at the age of 60.
Then we usually do a hearing test at least once a year.
And then we do it usually once a year, that's right.
Yeah, until we see that it's very stable. And then we may skip a year.
However, if young adults or anyone below that age has a concern about their hearing, or there's family history, or there's noise exposure or trauma, it doesn't hurt to get a test at any time.
Right, right.
What are some of the early signs of hearing loss that are often overlooked?
With children, like my son was sitting next to the television, and we didn't realize he had a hearing loss until many months later. But that's the reason he wasn't hearing. So he sat next to the TV as close as he could to the TV to hear. So also, people say, "What did you say? What did you say?" And they miss things, especially in a restaurant. It's very difficult when there's noise to hear the conversation going on if you have a hearing loss.
It's all about speech. You know, in kids it's basically learning speech, and in adults it's understanding speech.
Okay, the next question. Can hearing loss ever be reversed?
Yes. In certain medical conditions like sudden deafness due to a virus, or Meniere's disease due to too much pressure in the ear, steroids many times will bring back the hearing, reverse the hearing back to normal or improve it if it's given early enough.
What are some of the best ways to protect your hearing?
Basically, it's preventing, protecting yourself from noise exposure. As they mentioned earlier, that's one of the leading causes of hearing loss. Now, the good part about that is once you're away from the noise, you stop, the noise exposure. There's no further progression in the hearing loss. Now, there may be a further progression due to genetics, but the noise won't cause hearing loss any further if you don't have that exposure.
But if you have to work in an environment with loud noise, or you're going to be in loud noise, the dual use of the foam earplugs as well as the ear protection, the hearing muffs that protect your ears from loud noise, are highly recommended if you know you're working with lawn equipment for your job, or, different types of loud noise exposure for recreation or work or otherwise.
One of the other things that you can tell whether the noise is affecting your hearing is that after the noise stops, if your ears feel full, or you have ringing in the ears, or the ear feels stuffy, or you feel that your hearing is down a little bit, then it's probably been caused by the noise. And if you're lucky, that hearing will come back and the noise will decrease in your ear.
What are the differences between over-the-counter hearing aids and hearing aids from an audiologist or hearing center?
So over-the-counter hearing aids are kind of like getting readers for your eyes. They're not a prescription-based acoustic sound. It's basically like turning the volume up on the TV or lower, whereas prescription hearing devices are programmed to meet the needs of your specific hearing loss at each frequency for each ear. So it's very prescribed. It's very more exact of what your hearing loss requires, rather than just like the reader glasses approach for your eyes versus a prescription eyeglass set of eyeglasses. Now, I will say that some amplification is better than zero amplification, so it does help people that are not willing to go to an audiologist and their ENT to have a prescription set made, but I highly recommend that be your first choice. But if it's over the counter or nothing, then over the counter is better than nothing. You, doctor, have anything to add to that?
I think that's true.
Okay, the next question. Do earbuds or headphones contribute to hearing loss?
Yeah, they can. Obviously, if they're turned up too loud, and it can cause hearing loss.
Yeah, think about the proximity of the sound source is closest to the ear, and the volume can be at dangerous levels that can cause hearing loss. So absolutely.
So one other things about noise in the ear, can make the cochlea hypersensitive to noise. Instead of the hearing loss, patients' ears become hypersensitive and they can't tolerate noise or sound. And that's called hyperacusis, which we have a treatment for now.
Actually,
So not only does the noise cause hearing loss, but it can cause sensitivity, hypersensitivity of the cochlea to noise, to sound.
actually, that brings us to, there's a question in the chat section. And this patient says that they have hyperacusis, tinnitus, and now hearing loss. It says that my hearing test says I can't hear high frequencies, but I can't hear when my husband talks. His voice is very low frequency. TV is hard to understand without closed caption. What actually is happening here is that if you have a high frequency hearing loss, well, let me backtrack. To understand words, you have to understand the consonants in a sound, in a word. And the consonants tend to be a higher frequency than the vowels. And so if somebody has a soft voice or a low voice, that kind of accentuates the need to hear the higher frequencies and understand the words. So this is why probably in this patient, because they have a high frequency hearing loss, they can't hear the consonants, and because of that, they can't understand what people are saying. Dr. Silverstein, you could probably talk more about the hyperacusis and tinnitus associated with this.
Well, we do have a procedure now that we can, a minor surgical procedure that we can help people with hyperacusis. to reduce their sensitivity to sound, and they can go into more noisy environments with this little procedure that we do in the ear.
And I think the occurrence of the hyperacusis and the tinnitus, along with that difficulty, supports the fact that there's cochlear damage and there's hearing loss that needs to be identified and measured. It's definitely a combination of symptoms that point to hearing loss.
What is recommended as the next step when hearing loss increases and hearing aids are no longer working efficiently?
Talk about cochlear implants.
Yeah. Seth, why don't you talk about cochlear implants?
Well, actually, before we get to cochlear implants, maybe you want to talk about the ear lens. That
Good.
might be the next step as far as the bridge between a hearing aid and a cochlear implant. A cochlear implant is a surgical procedure where we actually place a microchip underneath the skin and an electrode that goes into the cochlea, the inner ear. And through a outside mechanism, kind of like a hearing aid, stimulates that electrode so that the hearing nerve is directly stimulated, and the patient, you can restore hearing in a lot of patients. It's not as natural as the hearing that most people have, but it is enough that, again, they can understand words and communicate with people. Dr. Silverstein, you want to talk about the ear lens, which is kind of like the bridge between the two.
Right. So if the patients have a certain frequency loss, a certain amount of loss, and certain amount of understanding still left in their ear, and the ear canal is large enough, then a mold can be made, and the lens is constructed that fits on the eardrum and held in place with some oil. And this lens vibrates due to a device that's placed out on the outside of the ear. And the frequency response with the lens is much better than a hearing aid. And it's probably not as good as a cochlear implant, but it's a good device in between the cochlear implant and hearing aid.
So basically, ear lens is recommended when you're not satisfied with sound quality with acoustic hearing aids. And the traditional hearing aid is acoustic energy that's amplified specifically for your hearing loss. The ear lens uses a low-powered radio signal to directly drive the eardrum with the prescription of sound over a broader frequency range, about 2.5 times the bandwidth or the range of the acoustic hearing aid. But there are limitations to degree of hearing loss and what your speech clarity or word recognition scores are. So you'd have to come in for an evaluation to see which acoustic, ear lens, or cochlear implant would be the most appropriate recommendation for you.
And another option is it's called a bone anchored hearing aid. And that's another bridge between the hearing aid and the cochlear implant. And what this device does is it directly stimulates the bone. It vibrates the bone to allow patients to hear essentially through the skull. And this is also for patients that maybe their ear canal is not big enough for a ear lens, but they still have fairly good hearing, that this device is another option. And that's a surgical procedure, but it's a small surgical procedure.
So a question came in from the chat, is ear lens covered by insurance? So ear lens is coded similarly to a traditional hearing aid. And every insurance policy is different, but typically insurance is limited to specific types of hearing devices, and it's typically the acoustic devices. However, if you have a hearing aid benefit, it's worth investigating whether the direct drive or ear lens device could be an option, but unfortunately, typically it is not. So that was a good question. They're all good questions.
What should parents look for in children with undiagnosed hearing loss?
So typically, if your child is not responding to the parent's voice, they don't develop speech. Hopefully you don't wait that long. But sometimes they'll pass their newborn hearing screening and develop ear infections or ear fluid situations, which decrease the hearing. And so they stop babbling. They're not developing speech and language at normal milestones. They don't respond to auditory information. You have to use visual cues to get their attention. Things like that. They're not responding as a normal hearing child to sound and developing speech and language and babble and things like that at normal milestones.
The fortunate thing is that if you can correct the hearing loss, kids usually catch up very quickly. And by the time they go to preschool, they're pretty much, back to where they would have been anyways. But if you delay it, if you don't correct the hearing and you let them go through that period where they're rapidly learning speech, it could be a lost opportunity.
Okay, the next question's from the chat. Do any of you have comments about the new Envoy Medical fully implantable CI?
Not really.
Must be real new.
The implants that I use are from Cochlear Corporation, mostly, and as well as Advanced Bionics. The Cochlear around the world is about 80% of all implants are from Cochlear. So they have excellent customer service. I'm putting a pitch in for them. I don't get any kickback from that, but they're the ones that are that have the most cochlear implants and the longest history of implants.
Okay, the next question. At what amount or level does noise cause hearing loss?
Yeah, why don't you put up that slide? So each person's ear is a little different, how it responds to sound and how much sound or noise it can tolerate before being damaged. But the government recommends 85 decibels at 8 hours a day is enough to not cause damage to the hearing. So 90 dB is like a hair dryer. An MP3 player is 100 dB. The rock concert's 110 dB. A plane taking off is 120 dB. And gunshots and fireworks is 140 dB. So obviously, the longer you're near the loud noise, the more damage it's going to cause to the ear. And I think each person is a little different on how they respond to the noise.
Actually, generally by OSHA standards, 85 decibels over an 8-hour period is essentially the cutoff.
Right.
But the time, as Dr. Silverstein mentioned, time and decibel kind of go in reverse. 140 decibels, I don't know off the top of my head, but it's just a matter of minutes as far as exposure that would cause damage. Whereas 85 decibels, it would take about 8 hours to cause damage. So if you go to the OSHA website, you could see what the time period is. Now, again, once the noise is gone and there's no further exposure, there would be no further damage. So it's not like sun exposure, where if you get exposure when you're younger, it can cause damage as you're older. When noise exposure, once it's done, it's done.
The next question is, what is a loudness discomfort level test, an LDL, and why would someone need one?
So we use the loudness discomfort test for patients with hyperacusis that have hypersensitivity to sound. And the audiologists perform this test, and they put the patient in the booth and put sound in their ear at a low level and increase it slowly until it becomes uncomfortable for the patient. And that's the uncomfortable or the loudness discomfort level. And we use that to measure how sensitive the ear is to sound. And it also helps us after surgery when we do that test to see how much improvement we get by putting the tissue in the middle ear to block the sound waves.
The next question, what happens to the brain causing hyperacusis? Is it known, or is there any research?
It's if the surgery does not help the patient, then the cause is probably in the brain. There's a hypersensitivity in the brain to the sound, and the brain cannot cancel the noise that's going into the ear. So in some patients, the problem can be fixed by dampening the little bones of hearing. But in those patients that don't respond, the problem is due to a hypersensitivity in the brain or the brain stem or the cochlea that can't be fixed by surgery.
The next question is, how can someone tell if they suffer from tinnitus or hyperacusis?
Usually tinnitus goes along with hyperacusis. Many patients with hyperacusis have tinnitus. And unfortunately, the surgery does not improve the tinnitus in these patients. And rarely does it make the tinnitus worse.
So I would add that hearing aids help tinnitus, sound therapy helps tinnitus, but by someone that's very knowledgeable, like we are here, with how much sound and what frequencies and what intensity level, so that we're not aggravating any hyperacusis, and we're actually treating the tinnitus by not only masking it so the perception of it decreases, but also alleviating the strain of hearing to the brain. So the brain, we call it cognitive load, and the brain can relax a little bit with hearing, and the tinnitus perception can be reduced. There are things that we can do to help tinnitus and lower the perception that the patient experiences. So again, an evaluation would be highly recommended, and talk about the treatment options.
The next question is there any new research or treatments for Meniere's disease?
Well, we've been researching Meniere's disease for the last 60 years and haven't figured out everything about the cause and how to treat it. But we've been pretty successful in a number of techniques to decrease the symptoms and make the patient's life better. And fortunately, many times the Meniere's disease burns out over time as a patient gets older. And but there are some good treatments for it that we use. And although we don't understand all the causes of it yet, we think that there has something to do with an autoimmune or immune reaction because it responds to steroids many times, which affects the immune system.
Next question is, how can you safely clean a child or an adult's ears?
Very carefully. Uh,
Holding them down.
what was that?
Holding them down.
Yeah, holding them. No. You you know, as far as a kid goes, basically you just use like a towel over your finger, you know, to try to wipe the wax out. And I wouldn't go any deeper. Definitely don't use a Q-tip. It especially in a kid, you know, with a small ear canal, you'll tend to push the ear wax further in. Earwax is actually made in the outer 1/3 of the ear canal. So if the wax is actually further in, it just means that somebody pushed it in. And typically that's with a Q-tip. The other thing is that I'm definitely against having the ears flushed out. A lot of times the wax in the ear, uh, you just can't flush it out. And what we do in the office is we remove the wax with um, you know, under a microscope, you know, very carefully, either with a suction or with a curette, like a scooper. Dr. Silverstein invented a device that can be safely used in the ear canal, if he wants to talk about that. But the biggest thing is that don't use water in your ear to flush it out, just because it tends to macerate the skin and could cause an infection. This is especially important if the patient is a diabetic. You don't want to flush it with water because you'll end up with an infection. Dr. Silverstein, want to describe your device?
Yeah, so about 15 years ago, I developed a method to irrigate the outer ear canal with alcohol and aloe. So it's like brushing your teeth. It's like it will not flush the wax out completely. It works when the ears are clean. It helps keep them clean by decreasing the wax accumulation. The alcohol is squirted into the ear a couple times a week in the shower, and it drips out. You just put it in the ear like that, and it seems to work pretty well to prevent a big accumulation of wax.
Also, it has a tip on it that is not long enough that it'll hurt the eardrum.
Right, the tip will not go anywhere near the eardrum, and the fluid flows out sideways, so it's not flowing onto the eardrum.
Okay, the next question is, what should I know about ear tubes if my child needs them?
Well, where do you want to start? Basically, you know, if the child comes in and has either recurrent infections or a persistent infection, usually over a 3-month period, then it may be indicated to put a tube in. The tube usually is done under a light general anesthesia. Um, if adenoids if it's usually the second time or the adenoids are extremely large, we might want to consider an adenoidectomy at the same time. The tubes usually last for about 6 months to a year and then fall out. Then the child is reassessed. While the tubes are in, the child has to be careful about getting water in the ear. If they do, it could cause an infection. And you'll know that it's infected when there's drainage coming from the ear. And that's pretty much it.
All right, thanks very much.
Thank you.
Okay, all right, bye now.